So as Megan already said, on each of your tables there are some of the ACEP guideline, one of the critical questions. Two tables I know have two questions. So what we're going to ask you to do is to review at the table the critical question. And I see if there's really very few people at a table, you might opt to maybe combine tables or something, just it'll make it a little bit lighter later. So if you review the critical question as a group and identify the 1 to 2 barriers to policy implementation, if you could imagine what that would be at your own institution or some kind of fantasy institution, and then outline 2 or 3 strategies for implementation or application in your respective setting, in your emergency department or whatever you try to do. Then what we're going to do after about 15 minutes of discussion, we'll ask one person from each table to get up to the microphone, and maybe in 2 or 3 minutes or so, because there's a lot of tables, to try to review with those answers, both the barrier and the strategy that you've come up with, and we'll have a scribe put them down on a sheet up here in the front of the room so that we could generate a little bit more of a discussion. So hopefully that'll go over okay with everybody while you're sitting and eating and thinking. Okay? Any questions or any thoughts? Knox, you want to say something?
Okay, so 15 to 20 minutes to review the opioid policy, look at the 1 critical question or 2 in these tables that you have, take some notes, have some discussion, and come back with a plan for us to improve on the guidelines, think about what the barriers are to these guidelines having an impact, and help ACEP decide what to do next in terms of moving these guidelines forward. So we'll re-talk to you in about 20 minutes. At this point, we want to stop because we want to get to a stopping point here by 1:30, and Lewis had to leave to do another engagement. He'll be back later to continue to contribute to the conversation. I'd like to ask our 2 tables to my left. Our 2 tables to my left. Who has critical question 1? Who has critical question 1? Either of the 2 tables to my left here? Okay. As I go around this way, anyone have critical question? What? You have 1? Okay. So we're going to scribe your answer here. If you'll come to the microphone. Who's speaking for the group? So for critical question 1, which had to do with the prescription monitoring programs, we'd like to hear your thoughts, recommendations, 1 to 2 barriers, 2 to 3 strategies for implementation, application, and we're going to have to keep a fairly tight time control over it. Go.
And I also want to just thank Jason Hop and Monica. I'm going to pronounce both of your last names wrong. I'm going to thank Jason and Monica for scribing for us. Thank you.
Watana.
So, all right. So our thoughts were that we had critical question 1 about the utility of prescription drug monitoring programs. And our thoughts as a table was that we agreed with the ACEP recommendations, that overall that they may be useful. We had a lot of anecdotal evidence for when a PDMP has been useful. It's helped us with diagnosis of patients who we suspected a possible OD. It's been helpful with deciding whether or not to prescribe opioids. And it's actually been helpful to some of the providers at our table in realizing that patients had had visits to other emergency departments recently, and thereby in avoiding other potentially harm-inducing interventions, avoiding another CAT scan, another LP, things like that. That said, we did bring up a number of issues, most of which were talked about in the morning, but those included the need for interstate communication. All of us live along I-95, I-75, big corridors, and that we find that patients go back and forth between different states. So there's a limitation. Yeah, it's a huge barrier is that we don't know what's been prescribed elsewhere. The delay in the uploading of information was also identified as an issue. The fact that if someone was in an ED earlier that night and had gotten a prescription and filled it, we might not know at the time that they come into our emergency department. The lack of effective alternatives and for pain therapy for these patients was identified as a potential barrier. We also had a lot of discussion about the fact that, as per the panel, it would be much more helpful to have this information pushed to us rather than us having to go search for it. We may not necessarily know that this patient should be flagged, and so if it could kind of show up as a flag, it would be more useful. In terms of next steps, things that we thought would be helpful was having, again, more kind of guidelines in terms of what to do if a worrisome PDMP screen is found, a patient education component, things that can get handed to the patients, or standard practices. We talked, each of us had very different practices about what we do, and we have a kind of worrisome PDMP flag when we look someone up.
So it's sort of a Pandora's box. You open it up, what do you do? Okay.
Exactly. What do you do, and kind of what's the standard, and you know, if we get a complaint, what's going to happen, and kind of what's the standard for our group, stuff that Kavita talked about. Another thing is kind of in terms of next steps is universalizing the protocols of how we handle those PDMP reports. In one of the states, they're not actually allowed to put the PDMP into the record. That it's, I think it was Indiana. In Indiana, they're not allowed to put their report into the record, so the next provider is going to have to go and look it up too, which then kind of limits the usefulness. Again, it's that kind of push versus pull problem. That's our quick and dirty summary. So thank you, guys.
Thank you. Well, where's our next table with critical question number 1? Up, 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 in the front. Yes. To the microphone, sir. So barriers and strategies, PDMPs.
So I think the other group hit on a lot of the similar topics that we discussed, and we agree with everything that you said. I think a couple other things that we did discuss is in relation to, there's a lot of legislative, I guess, policies coming down on who should be using it, when you should be using it. And in Massachusetts, we've just had a piece of legislation passed that mandates the use in all new patients. So they're
So in Massachusetts, a legislation that mandates the use, and it sounds as though that may create some concern because your eyebrows are going up.
So we're still waiting for the regulations on that legislation at this point, but there's a question on if we're not exactly sure about how to use this data once we get it, what sort of a legal ramification is if we don't intervene or we do intervene. Should we be mandating that all physicians use it? How does that take away from the physician's time at the bedside? Are we allowed to allow one of our basically front office staff to be able to look up the PMP data for us? And those are all questions we have as the country moves forward in wrestling with exactly how we use the PMP and who should be using it when they should.
Yeah, and I think the CVS pharmacy, there was an issue of late about mandating pharmacist use, and the pharmacists were a little concerned about this as well.
And then I think the other question we had too is I think the next step that we really need to do on the research end is linking this to outcomes, and whether that's what PDMP data in terms of what the reports say, and linking it to overdose outcomes and death. And it's a big challenge for those who are researching on it, our access to the data itself. So getting legislation passed to give better access to data.
What do you think the most feasible outcome is if you were designing this study? What would you go for?
I would want to look at
Deaths, mortality. Okay, great, thank you. I think the table in the back. You know, I don't know, is our microphone working or not? Battery's dead, you want to, yeah. We use that microphone too much, obviously, it wore out.
My name's Christina. I'm from the University of North Carolina. I'm going to try to not touch on things that the other two groups have. We broke it down, first of all, at the physician level. One of the barriers was concerned that they don't think it will make a difference to their practice. So creating some, in terms of overcoming that barrier, creating some educational material for physicians to show that actually this can impact your practice in a positive way. And again, outcomes data would be fantastic. And then at the hospital level, we'll need hospital buy-in in order to get information linked, for example, to the EMR to be a push instead of a pull. So creating information for a hospital administrative standpoint as to why they should invest in this or why they should work to approve nurses or other practitioners to be able to log in to get this information. And then at a state level, we've discussed the delays in input of data, and at a national level, the barriers across states and also across to the military system that we talked about in our group that we don't always have access to. So those were our kind of 3 levels.
Excellent. The MD futility
Yes.
idea. This is a futile gesture on our parts. And then the administrative buy-in, which goes back to some of the cost data we talked to earlier. Those are excellent points. Thank you. Any other takers for critical question 1? Done? Going? Okay. Let's start over here with critical question 2, to the left. Nope. Critical question 2, low back pain. 2. Okay.
So I'm Caroline Firemuth from Duke, question 2. So our question was, for patients with acute low back pain, are prescriptions for opioids more effective during the acute phase than any other medications? And we've identified a few obstacles, one of them being a lot of the patients that we see now in the emergency department come in saying, we've already tried ibuprofen, we've tried, hot baths and putting heating pads on, and we've tried all these things. And it doesn't necessarily mean that these things have failed. We still have, room to work with these patients. Have you maximized your dose of NSAIDs? Have you maximized physical therapy? Have you truly taken advantage of all your other things? Another one is identifying true allergies versus side effects of medications. So being a little sick to your stomach is not a true allergy to ibuprofen. And we can talk about, taking things with food, sending people home with, an antiemetic if it really makes them that sick to their stomach, and trying to minimize some of the side effects. One of the other things we talked about was patient expectations. A big thing in the news now is, pain management equals opioid medications, and it's really hard to get past that for patients, especially, when their neighbor or their mom or whoever else they know, has all these pain pills sitting at home, and I took one of my, buddy's pain pills before I came in, and that really helped, and that's all I need you to do for me. I already know what the solution is. And so really working on patient education, talking about some of the dangers of opioid medications, working with the primary care physicians to say, especially on these patients who have chronic pain, when you have an acute flare, let's talk about some of the things you can try, calling me or going to physical therapy or, taking it easy for a day before just jumping right into going to the emergency department. And if you look around at some of the other national groups, they're on our side. If you look at some of the same policies from the American Pain Society and, the family practice medicine, they all come up with the same policies that we have, and we're all, on the same side. So if we can use our colleagues, that'll really help us out a lot. And then truly giving patients good instructions when we discharge them. We all know that patients may or may not read all the discharge instructions that you give them, but having that conversation with at least a few of the high yield points coming directly from the provider, whether it be physician, nurse practitioner, whoever's caring for the patient, if you could take just a few minutes and say, these are some of the high yield points before they go home, that might help.
Great. This was the patient-centered table. That's excellent. The idea of actually changing the way those allergies have been reported for decades and decades is ambitious. That's great. Table number 2, or question number 2? Yes. Oh, sorry. Excellent.
Well, I'm going to be a lot less verbose, I guess. That we just looking at the guidelines. So we thought that for 2, opioids should be reserved for more severe pain. It's so nebulous. It's really tough. Like, what is more severe pain? So hard to judge. But I don't know what the answer to that is. And then for number 3, the prescriber should consider the patient's risk for opioid misuse, abuse, or diversion. I mean, there's no way to. I don't even know how to begin on that question. But we thought maybe advocating for ACEP, advocating for research and developing a short, user-friendly tool for screening for opioid use and diversion might be really helpful. Because there are long tools that none of us will use that are excellent, but they're not short. And maybe developing a best practice for low back pain. Maybe there's one out there that, and maybe we should publicize it if there is one. And the fact that there was no level A or B data was a little disturbing. You know, it is with most guidelines, but it would be nice to have some level A or B data looking at low back pain and what really works. That's what we have.
Excellent. I'll recognize Monica Watana, who was my fellow last year and now a clinical instructor, who just received a small NIDA EMF Career Development Award with the goal of trying to work toward developing an emergency medicine or department-friendly screening tool, because it is so difficult, and current tools are lacking. Critical question 2. Any other takers? Two, going twice. Okay, critical question 3 to my left. Okay, 3. Up 3. Okay, great. So this is the Schedule 2 versus 3 question.
So we were a small group, 2 of us.
But powerful.
We did our best.
Powerful.
We thought in this particular question that education for both physicians and patients to differentiate between the relative risks of addiction between Schedule 2 and 3 were probably one of the largest impediments here. I'm old enough to appreciate the difference between having to write out a Percocet prescription versus being able to just generate a Vicodin prescription. However, now that most emergency departments are moving towards all of your prescriptions shooting out of a machine, I don't know that there's that much of an appreciation of the difference between the Schedule 2 and the Schedule 3s. And we also identified that this is a patient-driven issue. Very often patients will come in and say, oh, well, Vicodin and Orco doesn't work for me, only Percocet, or that one that starts with D. And I would like a script for, my doctor who won't get back for another 3 weeks, please. So we found that was probably the biggest barrier to sort of implementation of this. And to that, we thought that perhaps in the writing of the recommendations to be a bit more clear about which narcotic prescriptions that are generally written are actually oxycodone versus hydrocodone would be helpful to include in the level C rather than in the level B section. And perhaps writing in the level C, it says support and then inadequate, which is kind of a positive negative. And so we just thought that maybe wording it a bit more directly by saying research evidence does not show benefit of superior pain relief for short-acting Schedule 2, i.e. oxycodone, over Schedule 3, i.e. hydrocodone, would be perhaps a bit more direct way to word that particular statement.
That's well taken. I think a lot of that has to do with writing by committee. Oftentimes you end up with some awkward phrasing. That's democracy, I guess. But good point.
Yeah. And then the last thing that we thought is that upfront patients should be aware of the fact that if they are going to request prescriptions for Percocet and Dilaudid, that they should be aware of the higher risk of substance abuse and addiction that those medications can confer based on their schedule. And that should be something that perhaps should be included in the recommendations if people are going to choose to prescribe those over the Vicodin.
Okay. Thank you. Critical question 3. Got another one? Okay. Is this patient-centered?
We spent an awful lot of time talking about the last question, so we don't have nearly as much to say about this one. But one of our things was also, we would like to start with the lowest dose possible to treat a patient's pain level. So definitely Schedule 2 is less than Schedule 3, so we'd like to start, sorry, I'm getting it backwards. Hydrocodone Schedule 3 is lower dose than your Schedule 2, so we would like to start with that, see how patients tolerate it. You can always step up. It's always harder to step down. One of the concerns that was brought up is hydrocodone is not available just as hydrocodone. So, those patients that you do see who come in with liver failure and, maybe you don't want to give Vicoprofen either because they've had a recent GI bleed, sometimes Vicodin is not an option because it does have that Tylenol or that ibuprofen component. So you have to take that into consideration as well when you're thinking about side effects and dangers of these medications. It was brought up by one of the leaders of our group that hydrocodone products are one of the most widely prescribed medications in the United States. But then when you look at long-term overdoses, hydrocodone accounts for a very small percentage of that. So again, to point out risks to the patients, especially that, people can overdose on these medications is important.
So patient education about risk as well. Yep. Great, thank you. We're going to have an applause meter at the end. So, question number 3. Yes, yes, no, yes, no. Okay, moving along. Critical question number 4, having to do with the treatment of acute exacerbations of chronic non-cancer pain. The table to my left, no?
Melissa Halliday. I'm one of the second-year Tox Fellows at Emory. So I'm going to be brief on what we talked about on question 4. So we definitely agreed with the recommendations that were there, but the second point that's under the level C recommendations talks about having the prescription being for a limited duration, and then also assessing the patient's risk for further abuse or diversion, those type of things. And I think one of the biggest barriers we talked about related to that is how do we assess risk? And I know this was brought up previously, but is there an easily usable score or some sort of tool that we can use in the emergency department to assess these patients? And we talked about that in relation to either a tool or using the PDMP. And the PDMP sometimes tends to be punitive, and you use it as I know you're possibly addicted to these medications, so in effect, get out of my ER. But it doesn't necessarily help the patient that we've created this addiction in. And so if we had a risk score, it's something that we could then use to refer to whatever treatment programs our hospitals have. And so that might be something that's more helpful, but again, it needs to be usable, and there needs to be education on it, both at an attending level, but also a resident level as well, because this is such a large problem that's going to continue for a while. Training the new physicians, I think, would be very helpful as well. As far as...
By the way, do you use a standardized risk score at Emory? Is there,
not
or
that
do you recommend
I know
one?
Of.
Or
not that I know of. I know there's some ongoing research in opioid abuse, those type of things, but it's very new from my understanding.
Does anyone in the room use a standardized score? If you're not a research project, but in practice, does anyone use a standardized risk score for patients in this room, the most committed room in the house here? Okay, go ahead. Sorry.
I'm glad I'm not the only one that doesn't use it.
Just wanted to share the blame.
The step 3 talked about honoring existing patient-physician pain contracts and treatment agreements. And so one of the biggest barriers to this is, again, has been talked about before, is the access to patients' previous records, whether it's pain contracts that exist, whether it's psychiatry notes, previous treatment notes, both within your hospital, but then in other institutions in your state. I did my training in emergency medicine at IU in Indianapolis, and theirs was probably one of the most unique IT systems I've seen, where they actually link multiple different hospital systems. And when you search into the system, you can find their visits at multiple different hospitals. There is some information that's protected in private, some HIV status, psychiatry notes. But one of the hardest things that we find is getting this information. If they were seen at, a Kaiser clinic and then I see them at Emory, I may have never seen them before and have that information. So having a discussion both with our EM IT people, but then also at a state level and at multiple hospital systems levels of how we can safely and legally join our information so that we can treat and approach these patients a little bit better, I think is helpful as well. And then we also just talked about the barrier of there are many patients who have gotten clever, for lack of a better word, and are able to change their name just slightly or those type of things. So when you look them up in the prescription drug monitoring program, you may not see all of their prescriptions. And so trying to figure out some sort of identifier, we spoke that often the date of birth doesn't tend to change,
right.
So keeping our searches as basic as possible, but that's what we identified around our topic.
Excellent, thank you. Yeah, we recently had someone from Indianapolis, JT Fennell, is that right? Yes. Yeah, come to talk to us at MD Anderson or around the Houston Regional Health Information Exchange. Very impressive operation. Critical question 4. Panning around the room. Question 4, and you are the final response. Thank you.
I'm Dawn Null from Hancock, Michigan, Upper Peninsula, almost Canada. Our question 4, as they just went over, focused on the short-term prescription for narcotics, less than a week for acute exacerbation of chronic pain, and also the honoring of the patient-physician contract that may already exist. And one of the things that we discussed was, as far as breaking the acute cycle, we tried to discern, is this going to be something for someone who has chronic daily pain, and they're just here because they have a subjective, increase in their pain, or is there an acute event that caused a worsening of a chronic problem? And so should we treat that more as just acute pain? And basically, we felt that one of the barriers would be is how do people discern the practitioner is what is acute and what is the best way to maybe break that acute cycle. So would it be better to prescribe a short term, maybe just a couple days of the narcotic prescription, and then get them back on their chronic regimen through their doctor's office? And so that was our main concern, is trying to mobilize the patient to get them back to their baseline as quick as possible. And so, different practitioner methods and interpretations of what is acute, I think, would be a barrier. For the other component, we didn't discuss that much, but I think access to the primary care contract, I think it's a lot better now that there are EMRs, at least in our small area. It's very accessible because we have such a small practice group. We basically all work for the same provider. But as far as, having access to that, I think that would be a barrier. Although, honestly, I think just in my experience that the contracts that are done in the outpatient are very rarely honored in the ED, just because we feel we're not a part of that. So one of the things that we're trying to work on in our institution is, working together with the outpatient physicians so that we do have a consistent approach. So.
Great, thank you. Is there any table that we haven't heard from? Are there any attendees who want to give feedback to ACEP on the general output of the opioid writing panel, or have the immediate next step that ACEP should be taking? Ed, I know you have something to say. Up here to the mic.
This is a pet of mine, that in the ACEP guidelines, this is, we cannot distribute methadone in the emergency department. So I would like to call on the group to think about this, because we have patients that stay there many hours, and they've missed their dose because of us. They're registered in a program, they go there daily, and they're really working a program. I think we can disrupt their care, and also we wouldn't treat them we wouldn't deprive somebody of their hypertensive medicines or any other medications if they were in the ED for a long period of time, and I think ACEP is wrong in having a hard and fast rule. Obviously, we don't want to attract people to come to the ED for the methadone, but we can build in some more protections against that.
So a laxer policy on methadone. Anything else? Yes?
I'm far from the mic, so I'm going to talk loud.
Okay, you're going to talk loud. I'll repeat what you say. Okay, I know you can.
Is that we weren't sure if all of this is just a shorthand for all controlled substances, or are they only focusing on opiates? Because at least at our institution, we have a controlled substance policy, not an opiate policy. So what I would hope is that their approach to this would include not just narcotic, opiates, but benzodiazepines and related medicines, anything with abuse potential like that.
Right. So the idea that we should expand the opioids guideline to include other controlled substances, and in particular benzodiazepines. I think the guideline does mention the combination of opioids and benzodiazepines, but only peripherally, and it wasn't really a focus, and perhaps it should be. With that, Katya, are we good? Yeah, we're good. Okay, we're good. We have a, yes, round of applause. Absolutely. Yeah, thank you. Thank you. The woman in the red dress, a round of applause. And so now we have a break for everyone to stretch. We're going to reconvene at 1:45. The afternoon is really talking about solutions, so I'm looking forward to that. Thanks.